for quality implementation programs at the Society of Critical Care Medicine. I have no relevant disclosures. This webcast is funded by Society of Critical Care Medicine's Council to encourage implementation of 2013 clinical practice guidelines for the management of pain, agitation, and delirium in adult patients in the ICU. Thanks for joining us. You're invited to ask questions to our presenters throughout the webcast. You may do so by typing your questions in the question box in your GoToWebinar panel. Questions will be addressed after the presentation. This webcast will include approximately 40 minutes of content. Due to the short nature of this educational activity, there will be no CE/CMEs offered. You will also have the opportunity to participate in an interactive poll. When you see the poll, simply click the bubble next to your choice. This webcast will be available at www.iculiberation.org or on SCCM's YouTube channel. We invite you to share this and the many other ICU Liberation webcasts and patient stories with your colleagues widely. Post on Facebook if you like this webcast, and if you tweet on during the webcast to spread the word. It is now my pleasure to introduce our moderator and speaker today. Our first distinguished presenter today is Dr. Kathleen Puntillo. Dr. Puntillo is Professor Emeritus and a research scientist at the University of California, San Francisco. She's had a long program in ICU research, teaching, and clinical activities related to pain and other symptoms, as well as palliative care for ICU patients and families. Our first co-presenter for today is Dr. Celine Gelinas. Dr. Gelinas is an associate professor at McGill University and a clinical researcher at Jewish General Hospital in Montreal, Canada. Dr. Gelinas' research program focuses on pain assessment and management of critically ill adults. She is the primary author of CPOT and has an interest in non-pharmacological strategies for pain management in the ICU. Our second co-presenter for today is Dr. Joffe. Dr. Joffe is an associate professor of anesthesiology, an attending physician, and an associate medical director for respiratory care at the University of Washington, Harborview Medical Center in Seattle, Washington. Dr. Joffe has been a member of the past and the current SCCM PAD Guidelines Committee. So I'll now turn it over to Kathleen to begin the presentation.
Good morning. I, too, would like to add my welcome today to you for the SCCM webinar. And I wanted to start out by saying I have no conflicts of interest to disclose. What I'd first like to do is go over the course objectives with you, and the hope is that after you've completed this program, you'll be able to, number one, describe the importance of pain assessment and its analgesic management within the framework of the ABCDEF bundle. We'll say more about that shortly. Second, to discuss the assessment of pain in non-communicative patients in our ICUs, particularly through the use of the CPOT. Third, we're going to explore and evaluate pharmacologic management options for treating pain in critically ill patients. And we're also going to provide answers to frequently asked questions about pain assessment and management challenges. So let me start by saying this webinar is part of the ICU Liberation campaign that has as its overarching goals to improve care of critically ill and injured patients, and doing so by improving assessment and the prevention and management of commonly experienced conditions, while at the same time we want to use an integrated, interprofessional, team-based, and bundled approach to care. And what we also want to stress is that the purpose of today and for our practice setting is always to improve patient comfort. So first of all, I hope that everybody who's on our webinar today knows their alphabet, because we're going to talk a lot about it. In particular, if you look at this slide, at the ICU Liberation slide, at the right-hand side, you will see what I mean by the alphabet, the ABCDEF bundle that's shown in one of the right-hand columns. A for pain, assessing, preventing, and managing. B, for spontaneous awakening breathing trial, C, choice of sedation, D, delirium, E, early mobility and exercise, and F, family engagement and empowerment. But again, today, focusing on the left column, we're going to emphasize pain, its assessment, and its management. So this is part of SCCM's Pain Care Bundle that was first published in 2013, the publication of the Pain, Agitation, and Delirium Guidelines. And so concerning the Pain Care Bundle, what we have in that is the assessment of pain, and I want to stress the assessment of pain and talk about what significant pain is, and we will talk about that a little bit more later. The treatment of pain, specifically, the goal is to treat pain within 30 minutes of detecting significant pain, and then preventing pain whenever we possibly can. And then one of the times that we can do that is to treat pain before sedating or treating for patient agitation, because the reality is the patient might be agitated because he or she is having pain. Now, why do we stress the importance of pain and pain assessment and management in the critically ill patients? Well, to answer that, let's provide the context. First of all, pain affects the overwhelming majority of patients that are in ICUs, medical patients, surgical patients, those who are ill, those who are injured, patients undergoing diagnostic and treatment regimens. All of them are at high risk for pain. Secondly, we know that patients that have diminished communication or cognitive capabilities are at risk for pain because of these inabilities to communicate their pain. And that brings us to a third very important point, and that is that reliable and valid pain assessment is the foundation for effectively treating pain. Choosing the best intervention to treat ICU pain is often very challenging, even if we have done a very good practice of assessing their pain. And finally, viewing pain assessment and treatment through the lens of a multifaceted quality care is the optimal approach. So with that, what I would like to do is turn over the presentation to Dr. Celine Gelinas.
Thank you, Kathleen. So I'm very pleased to talk to you about pain assessment in the ICU. I have no conflict of interest to disclose. So my objectives are very focused on the assessment of pain. I'll introduce you to the CPOT scale and we'll view some videos to practice with it. And we'll have some relevant questions related to pain assessment challenges. So pain, the definition of pain, many of you may be familiar with this one. So it's subjective. It's something that is felt by a person, and it's defined as being unpleasant with a sensory and emotional component. And this implies that it has to be reported by the person who is experiencing it. But many individuals cannot self-report due to various factors, especially in the ICU. And it's only recently, a few years ago, that the International Association for the Study of Pain acknowledged that the inability to communicate verbally does not negate the possibility that a person is experiencing pain and is in need of pain treatment for relief. So let's start with a brief case. So you're a nurse responsible for Mrs. Diaz. She's in your ICU. She just had cardiac surgery. She's conscious and alert. Even when she's resting, she's grimacing, protecting the sternal incision. She's tense, she's rigid. She also acknowledges that she's in pain, and she doesn't want to move at all. And she has the following vital signs for blood pressure, heart rate, and respiration, which is also shallow. So considering the information you have for this patient, which of the following methods are the most appropriate to assess your patient's pain? So A would be changes in vital signs, B, use of a behavioral pain scale, C, attempt to obtain the patient's self-report. D, ask the family. E being the first three, and F, all of them. So what would be your answer? The correct answer is C, attempt to obtain the patient's self-report. So the American Society for Pain Management Nursing proposed a very well stepwise approach for pain assessment in those unable to self-report, in which the first step should always be to attempt to obtain the patient's self-report because it's the gold standard for pain assessment. And a simple yes or no should be considered a valid answer in self-report. When the self-report is not available, we should look for behavioral changes or use a standardized and valid behavioral pain scale. The family can also provide us with very informative information about the patient and pain behaviors. And lastly, when sources of pain are present and we have sufficient reason to think that the patient is in pain, we should attempt an intervention for pain relief. Let's put you in a context. So you're part of a committee at your hospital aimed at improving pain assessment and pain management. The FLAC, which is a behavioral assessment tool for children, is used in the pediatric department for this population, and the committee wishes to implement this tool in the adult ICU. Such a decision is fine, as pain assessment tools can be used for any patient population and in any context of care. Is that true or false? So the correct answer is false. And the reason for that is that validity is not a characteristic that is related to the tool itself. It's related to its use, and it has to be related to a specific purpose, patient population, and context of care. So tools has to be carefully selected for the patient group and the context of care where you want to use it. This article is a detailed report of the analysis we did of psychometric properties of 8 different pain scales that were developed and tested in nonverbal critically ill adult patients. And from these, the BPS, which is the behavioral pain scale developed by a team from France under the leadership of Dr. Jean-François Payen, and the CPOT, which is the critical care pain observation tool, showed the most robust psychometric findings for their use in this specific patient group and context of care. So for the purpose of time, and for this presentation, I'll be focusing on the CPOT. So as you can see on this slide, the CPOT has 5 different behaviors, but actually we're using only 4 of them because we're selecting them based on the patient's condition. So if you look at the last 2, compliance with the ventilator and vocalization, so we will select one of them depending if the patient is intubated and mechanically ventilated or not and able to vocalize. So each of these items are rated from 0 to 2, and the possible total score is 0 to 8. And as you can see, the more points the patient will get, so the more intense will be the behaviors. So for facial expression, and we'll see some pictures shortly, so a score of 2 if the patient is relaxed. If we see some tension in the upper face, mainly related to brow lowering, it's a score of 1, and a full grimace is a score of 2. Similarly with body movements, so no movements being 0, 1 for protection, like the patient's moving towards the pain site, agitation or restlessness being a score of 2. Muscle tension is assessed by performing a passive flexion and extension of the patient's arm, and the more rigid is the patient, the more points he or she will get. Compliance with the ventilator, a score of 0 if the patient is tolerating the ventilator and movements. If alarms are on but stop spontaneously and there's some coughing, it's a 1. And if it's clearly more fighting the machine or the ventilator, it's a score of 2. And for vocalization, so no sound or normal tone is a 0, sighing or moaning will be a score of 1, and crying out or sobbing will be a score of 2. So in these pictures, you can see a grimace in a patient who's intubated or not. So this is described with the brow lowering, the eyes that are tightly closed, and the nasal furrow that we will see appearing between the nose and mouth. Sometimes we see patients biting their tubes as well, or opening their mouth. And you can also access a free teaching video for the CPOT on the ICU Liberation website if you want to have more information. So this is a picture of a patient grimacing where we can clearly see the brow lowering, the orbit tightening. The nasolabial furrow is also present even of the fixation of the tube, and the patient is slightly opening the mouth, maybe because of the presence of the tube, but we can even see his teeth. So to use the CPOT, we have to obtain a baseline score first, and we usually do this when the patient is at rest, and we do a 1-minute observation. We will repeat the assessment during procedures, especially those who are likely to be painful to patients, like turning, for example, and before and at the peak effect of an analgesic. We always give the highest score that we observe, and we give a score for each component. So compliance with the ventilator or vocalization, depending if the patient is intubated or not. And muscle tension we will assess last, because just touching the patient may stimulate the patient. So we'll try to do this at the very end. So the CPOT can be used in patients who have intact motor function, at least on one side, and ideally no brain injury that affect the level of consciousness. So this is a question for the audience about the use of behavioral pain scale. So the use of a behavioral pain scale is useful to determine pain intensity, determine if pain is present or not, evaluate the effectiveness of a pain management intervention, B and C, which is pain present or absent, effectiveness of the intervention, or all of these answers. So you have 15 seconds to answer this question. Interesting. So we have 2/3 of you who answered A, B, and C. And the correct answer is B and C. So 29% of you got the correct answer. So I'll get into this right away. So a behavioral score is used differently from a self-report score. So these are not equal scores, and this makes sense because a self-report measures the sensory component of pain, what a person will perceive and feel, but when we use behaviors, we are using observation, and we are using more objective signs that can be related to pain. So even if they are correlated, so when one goes up, the other will go up, they do not mean the same thing. So a behavioral score is more useful to detect when pain is present or absent, and can also help in assessing the effectiveness of interventions. So let's practice with the CPOT. So this is the first patient that I will play for you, and I will comment. So we see the frowning here, the brow lowering. Around the mouth, we don't see much contraction. So it's more in the forehead that's it's present. And now we'll see him with the body view being turned. So he's holding the pain side very tightly, during the turn. You look stiff. The best way to assess muscle tension during turning is really to feel your patient being tense during the movement. But visually, we could say that it doesn't look totally relaxed. So if we do a CPOT score with him, so facial expression, as it was more in the upper face, it's a score of 1. Body movement, so protecting the pain site, a score of 1 as well. Muscle tension, we can assume a score of 1. And compliance with the ventilator, it was difficult to hear, but there were no alarms. So for this patient, it would be a score of 3. So now it's your turn. So you'll be viewing this patient, and then I'll be asking you what is your CPOT score. So it's important that you pay attention to her reactions, because I won't be commenting on them. Okay. So now it's your turn. So what is your CPOT score for this patient? So your choices are a score from 1 to 5. And you have 15 seconds again. Okay, so the majority gave a 4, and it's the correct answer. So just briefly, her facial expression involved not just the upper face, but the lower face as well, so it was more grimace. So if I go to this slide, so facial expression score of 2. Body movement, she touched her head during the turning. She was protecting her head, and so it's a score of 1. Muscle tension, it's difficult to say, so she seemed to be quite relaxed compared to the previous one, but she moaned during the turning, so a score of 1 for vocalization, so a total of 4. So just going back to the PAD guidelines for the use of BPS and CPOT, which has been shown to be the most valid behavioral pain scales, there were not much evidence for brain-injured ICU patients. So I just want to give you a glimpse of some data that we have on critically ill brain-injured patients. So this is unpublished data for now. So this is a study in progress. We observed 147 patients at different times, and behaviors that we observed more. You have some examples here, but eye-opening and brow lowering were still present in more than 3 out of 4 of them. Grimace was mainly absent, and that was very interesting because grimace is part of every pain scales. The more conscious they were, the more behaviors they exhibited. And very interestingly, we found a moderate correlation between the number of behaviors and their self-report of pain, and only 33 out of 100 were able to provide a self-report for their pain. So, vital signs now. You can be confident that your patient is in pain if he or she presents increases in vital signs and then treat pain accordingly. Is that true or false? So the correct answer is false. Unfortunately, we don't have much evidence to support the use of vital signs for pain assessment, and they haven't been found to be valid for this purpose. An absence of change doesn't mean that a patient has no pain, and vice versa. So vital signs should only be used as cues to begin further assessment of pain with appropriate tools, in this case being behavioral pain scales. So what to remember? So assessment of pain should be done not only at rest, but also during care procedures, as well as before and after you administer an analgesic. Self-report should always be first. When the patient's self-report is not available, then we turn to validated behavioral pain scale, and we have two pain scales that are valid for this purpose. Self-report score doesn't equal a behavioral score, so it's very important to keep in mind, and when you develop pain management protocols, you have to take this into account as well. So I thank you for your attention, and I'll now turn it over to Dr. Aaron Joffe.
Okay. Can you hear me okay? And we're advancing to the next slide. Excellent. Okay, excellent. So Kathleen, okay, Kathleen and Celine, thank you for allowing me to participate with you and to discuss the pharmacologic treatment of pain in the ICU. I also have no conflicts to disclose related to this talk. Today, I will be discussing specific pharmacologic agents that can be and are often used to treat pain in the ICU. I'm hopeful that at the conclusion of our session, the listener will be able to describe some of the more commonly prescribed analgesic medications used in the ICU. In addition, I will discuss frequently asked questions regarding this topic. Let us begin with a question, and this will be a poll question. I will add some detail to the question as it appears on the slide as we walk this through. You have this relatively young man who is being treated in the ICU for sepsis from a necrotizing soft tissue infection involving the perineum. He underwent a single surgical debridement 72 hours prior, and the small wound he has is clean and dry. He is conversant, he's on 2 liters of supplemental oxygen, and he is hemodynamically stable without need for vasopressor support. The bedside nurse relays to you that he is constantly complaining of low back pain. On discussion with the patient, he endorses a history of chronic low back pain from an old sports injury, for which he takes Percocet 5-325 regularly, 2 pills thrice daily. Which of the following options best describes this patient's baseline analgesic need? And again, you'll have the requisite 10 to 15 seconds to answer. So good, about 50% of you, or about half of you, got the right answer, which is that he is a high opioid consumer. And we're going to come back to the issues raised by this question in just a couple minutes here. So first, let me say that I understand how complicated the ICU environment is and how very simple, seemingly unimportant things can often be overlooked. It's my personal belief this is particularly true in the way that we deal with the patient's need for analgesia. Many patients, like the one I have presented in the preceding question, can in fact indicate a location and severity of their pain if we take the time to actually talk to them about it. Of course, the more awake and communicative the patient, the more information regarding their pain you will be able to derive. The PQRST method is a tried and true interview method and should be your default manner by which to assess a patient's pain at the bedside. This is extremely important in order to avoid a one-size-fits-all approach to pain in the ICU. The ability to differentiate somatic from visceral, from neuropathic, from particular type of pain, just as examples, on a clinical basis alone, can be very helpful in choosing appropriate medications, which we will go over in the following slides. In the question, the patient has told you the location of his pain and, in fact, how he already treats it. Further questioning of the patient may allow the clinician to anticipate provocations and or timing in a manner that allows for avoidance of further exacerbations of the pain or prescriptions for appropriate preemptive analgesia. And this has nothing of what he may require as a result of his surgical wound. It's also useful to differentiate this type of strategy from the patient who is nonverbal that we've mentioned and mechanically ventilated. In this case, it is often difficult to know what you're treating other than the patient appears comfortable or uncomfortable while they're on a ventilator. Now, some knowledge of the different pain pathways and receptors responsible for relaying pain signals and which may be amenable to pharmacologic treatment is helpful. In this slide is a diagrammatic representation of various pain pathways. Some of the colors, I hope, are showing up well. In green, or actually it looks like as a peaked green, is represented a small unmyelinated C fiber. Its major neurotransmitter is glutamate, which is regulated by calcium channels, but the signal is received postsynaptically by NMDA receptors, and you can see that in sort of the lavender color on the right. Another major neurotransmitter is substance P centrally, which modulates responsiveness, which is released in the substantia gelatinosa. Descending fibers represented here in a yellow color, which modulate responsiveness, are serotonergic, opioidergic, and alpha-2 adrenergic. And in contrast with the C fibers, the A beta and A delta fibers undergo depolarization, which of course is mediated by sodium channels. There's also an interneuron here, which appears on the screen as a light blue, where GABA exerts a modulating influence. So you can see that there are a number of receptors which can be targeted using commonly available medications, such as ketamine, lidocaine, gabapentin, clonidine, dexmedetomidine, acetaminophen, nonsteroidal drugs, as well as opioids. In the following two slides, I have listed specific medications. This first slide lists commonly and not so commonly used opioids. You will note that for each drug, you'll see an IV to oral equivalent when one is available, how long it takes the drug to start working, the half-life, the context-sensitive half-time, what a typical intermittent bolus dose happens to be, a clinically useful infusion dose range, and some pertinent comments about each of the drugs. For those of you who don't know, the context-sensitive term refers to the time it takes for a plasma level to decrease by half from steady state when the drug is being administered by continuous infusion, and is extremely important to note that this time is often much longer than the half-life, and that has clinical relevance for many of our ICU patients. You will also see that fentanyl is quite potent. It's approximately 100 times more potent than morphine. It's mostly metabolized in the liver to an inactive norfentanyl metabolite, but the parent compound may accumulate in liver disease, and when other drugs which utilize the same cytochrome P450CA pathway is used, midazolam being one of them, the parent drug will be metabolized at a slower pace and also may accumulate. Hydromorphone is about 7 times more potent than morphine. Both morphine and hydromorphone are metabolized to active compounds by the liver. They are then renally excreted, so both these drugs can accumulate in the setting of liver or renal disease. Interestingly, hydromorphone may in fact work in patients who are somewhat tachyphylactic to morphine or fentanyl. Remifentanil is a drug generally used in the operating room, but is used in Europe in the ICU as part of an analgesic sedation strategy. It has roughly the same potency of fentanyl, but the exact figures are somewhat elusive due to the unique pharmacokinetic properties of the drug. It is quick on and quick off, considered to act like a light switch. It is therefore context insensitive in that the plasma is effectively cleared of this drug within about 10 to 15 minutes, regardless of the time of infusion. Methadone is not an oft-used drug during the ICU outside of patients who are already taking it, but be aware if they are, or if you're using it, that methadone is a QT prolonging drug. Ketamine is an NMDA receptor antagonist. It is lipophilic and is extremely useful in patients who are high opioid consumers. When it's not being used with an amnestic agent, such as a benzodiazepine, it may result in hallucinations or bad dreams. Should be administered by or its use supervised by somebody who is intimately familiar with its use. Other non-opioids are listed in this slide as well. You should keep in mind that gabapentin, also known as Neurontin, was originally developed as an antileptic. It may cause sedation. It's available in an oral form only, and if it abruptly discontinued, could result in seizure. Its analgesic effects take multiple doses over a couple days to really work. Now, back to the question raised at the beginning, I have listed for you some common oral prescription opioids, some with the common trade names as well as the relative potency compared to morphine. The patient listed in the question takes Percocet 5-325, which is to say that each tablet has 5 milligrams of oxycodone with 325 milligrams of acetaminophen. There's a clinical pearl you can keep in mind that when the drug name ends in the letters CET, it will contain acetaminophen. In this case, the patient takes 30 milligrams of oxycodone at baseline for his back pain, which is equivalent to approximately 45 milligrams or more daily. A high opioid consumer is defined as one who takes greater than or equal to 40 milligrams of morphine daily, so this patient will qualify. This is important to note because it has implications for whether adjunct medications targeted towards decreasing overall opioid need while in the ICU and or one that helps modulate the pain response should be considered. I would also say that most of you will not need to memorize this slide or walk around with a conversion card. This is an excellent opportunity to cozy up to your clinical pharmacist and ask for their assistance. Next, I would like to use the following question to illustrate some points regarding a population whose pain may be both difficult to assess and treat, that being the neurologically impaired. This was already alluded to by Dr. Gelinas. Here you're presented with an elderly male who has suffered an intracranial bleed, likely resulting from hypertension based on its location. The ICH score that's listed here awards points for GCS, an age greater than 80, the volume of blood that is present on CT, the presence of intraventricular blood, and whether the nidus appears to be supra or infratentorial. In other words, it's a severity score. And what we're trying to tell you here is that from the standpoint of this patient's primary injury, the severity is relatively low. So which of the following is most correct? Of course, we would like to avoid all sedating medications when possible, so as not to confound the neurologic exam, but this may not be possible, and leaving pain untreated may result in agitation or confusion, which itself may lead to more problems and or unwanted neurodiagnostic testing. I will address the premise that traditional pain assessments cannot be used in a moment, but despite not being able to self-report or even being arousable, patients can still feel pain. So the most correct answer here is that non-opiates should be maximized first. This is data derived from 3 hospitals, 2 in Canada and another in the US, in patients being cared for in a neurologic, neurosurgical, neuroscience, or surgical trauma ICU over a 6-month period in 2011 and 12. It was a convenience sample, not consecutively enrolled patients. Pain was evaluated with a numeric rating score for those able to self-report or a behavioral score for those who were not. Exams were performed independently by a physician and a nurse. The intra-class correlation coefficient represents the inter-rater reliability of the assessment between the physician and the nurse's. Values of greater than 0.8 are considered quite good, and as you can see, that for the pain assessments, the NRS and the BPS, there is in fact excellent agreement. There were 151 patients evaluated in this study who underwent 439 assessments total. None of the patients were unable to have a pain assessment. The take-home point here is that while the validity of behavioral scales used in general ICU populations have not been extensively validated in neurologically injured patients, again, as Dr. Gelinas alluded to say that they are not feasible, that they should not be used over other subjective assessments would be incorrect. This study by the same group, but which preceded the last study, involved general medical surgical ICU patients. Providers were supplied with a protocol in a before and after manner for prescribing analgesics, which started with non-opioids and worked their way up towards opioids. What they reported as it pertains to the question I presented is that pain scores improved significantly, but additionally, the amount of opioids in morphine equivalents significantly decreased, while the proportion of patients who received no opioids at all significantly increased. Over 1/3 of the patients using this strategy did not receive opioids. Lastly, there seems to be a link between the severity of illness and the analgesics needed. That is to say that the less sick you are, the less likely you would need to require opioids, and if you did, the total amount was actually less. In this slide, I have listed here 3 references as a start, which all show the benefit of adjunct medications for analgesia, and they highlight that even if you use opioids, there is much you're able to do to decrease their dose and potential side effect profile. So what would I like you to remember here? Keep it simple first. Go to the bedside, and for patients that are able to communicate with you, try and use the PQRST method. Their pain may have nothing to do with the ICU, or they may have suggestions of how to treat it that may be better than what you're suggesting. High opioid consumers are considered those who take greater than or equal to 40 milligrams of oral morphine equivalents daily. Not all patients in the ICU will need opioids, so maximize non-opioids first when able. Untreated pain may contribute to agitation and or delirium, so you should treat to your pain score first. Validated tools in the general ICU are the best starting points for assessment in difficult populations, such as those who are neurologically injured. And it is with this, I will now return this back to Dr. Puntillo.
Thank you very much, Drs. Gelinas and Joffe, for your presentations. Let me summarize what we have been talking about so far. We began by emphasizing the importance of the overall best practices using the ABCDEF bundle, and then we focused our attention on the first letter of the alphabet, the A, which stands for assessing, preventing, and managing pain. And what we were told was that pain assessment is the essential first step to the understanding of what our patients are experiencing and what treatments they may need. It's very important when we are assessing patients' pain to match the tool to the patient's capacity. And it's important, again, to emphasize that a self-report score, say on a 0 to 10 scale, is not equivalent to a behavioral score. And it's also important to rely on research for tool selection. We then went to the management of pain, and Dr. Joffe told us that it's important for us to treat significant pain within 30 minutes, to treat pain first, and then to sedate if the patient needs sedation, and that opioids, while they might be the first line of treatments for a number of critically ill patients, it's important to consider non-opioids and multimodal therapies as you are making decisions. So we are going to complete our presentations now and then turn it over to you, the audience, by asking you, what are your challenges in providing comfort to your ICU patients? Now, what I would like to do to begin with is to address some of the challenges that the participants have raised during the presentation about different aspects of what they heard. Let me start with this question, and I would like to refer it to Dr. Gelinas. The participant said, our hospital uses a 0 to 10 self-reported pain scale for all non-intubated patients in the ICU or any patient care floor. Our administration feels this is important for a clear handoff between care units. Could you please comment on the use of the CPOT for all ICU patients as opposed to just intubated patients, whereby the handoff wouldn't be an issue because intubated patients are always in the ICU and don't change units? In other words, why can't we use the CPOT for all patients, Dr. Gelinas?
Thank you, Dr. Puntillo, for this question. I just want to make sure I clearly understood it. So why shouldn't we be able to use a CPOT on all patients in a hospital or any patient in the ICU who are not able to self-report? I just want to clarify that.
Yes, the question was for all patients.
For all patients.
In the ICU. For all patients
in the
ICU.
Okay. Well, based on pain itself being a subjective phenomenon, we have to start with the patient because the patient will tell what he or she is really feeling. When they are unable to self-report, we can use a CPOT on them, and even if they are not intubated, because part of the CPOT you have the vocalization item, so you can also rely on sounds like moaning or screaming, crying out. So these could be considered part of your assessment. So the CPOT has been developed to count if a patient is intubated or not, so you can use it. I don't know if that answer.
I hope that answered the participant's question. It was a very good question. It comes up a lot in practice.
Mm-hmm.
Follow-up question from the same person, Dr. Gelinas, is please also comment on the use of two different pain scales for intubated and non-intubated patients, especially since the self-report, as we're being told, doesn't equate with the CPOT score. Maybe you could emphasize your answer on the lack of being able to equate self-report scores with CPOT scores.
Okay, well, it's not just for the CPOT. I think it's for behavioral skills in general as well. And the difficulty is that we are measuring different components of the pain. So when we're using a self-report, we are measuring a perception. And when we are using a behavioral skill, we are using objective signs that we can observe. So these are not equal information for pain. They are related, but they provide complementary information on a patient's pain. And unfortunately, behavioral pain skills have been found to be not very good at detecting when pain is mild, because when pain is mild, it may not show on your patient. And just think of yourself when you have pain. So you will probably exhibit behaviors as your pain increases. So when it's mild, well, you know, it may not show very much. So this is why we cannot equal these scores because they give complementary information, and the behaviors don't necessarily capture when pain is mild.
Thanks very much, Celine. I'm going to direct this next question to you, Dr. Joffe. Aaron, the question is, what are your thoughts on IV Tylenol? Which patients should not receive IV Tylenol?
Good question. I think well, first let me say what how we use IV Tylenol here, and I understand that there are a number of administrations in pharmacy and hospitals who are reluctant to have it often prescribed because of the cost. And I would say that in general, anyone who you believe could get acetaminophen as part of their analgesic regimen is a candidate for intravenous Tylenol. And I think the way in which it can be used in an ICU environment in a cost-effective manner, although to be honest, this is opinion and anecdote, not necessarily data-derived, is that 1 or 2 doses of the IV formulation are useful to reach adequate therapeutic plasma concentrations quickly. Because of the variation in bioavailability, because of problems with absorption in critically ill patients, it may take longer to achieve a therapeutic level with oral or rectal Tylenol, or you may not actually get there. So we do not use IV Tylenol for every dose, but in the perioperative arena and in the ICU, we do use it as a load, if you will, for 1 or 2 doses, assuring that the drug we're giving is 100% bioavailable and that we will achieve some peak plasma levels that will be therapeutic initially, and then try and sustain that with scheduled oral or rectal Tylenol. So to come back to your question, anyone who can get acetaminophen orally or rectally, in my mind, is a candidate for an IV load of the drug, either 650 milligrams or a gram, to get that plasma level and then continue that therapy either orally or rectally to sustain that level.
Okay, thanks very much. Here's a second question for you.
Okay.
What are your thoughts? Do you use Toradol brain injury?
We do. We do. It depends on whether they're a fresh post-op patient, depends on whether there has been some bleeding. There's always a discussion with the neurosurgeons. But for the most part, we do use ketorolac, again, keeping it under 48 hours as an adjunct. If they're able to take orally in patients who are candidates for getting a nonsteroidal, we may just give them oral ibuprofen or put the ibuprofen down their nasogastric or an oral gastric tube.
Very good. Can everybody hear me?
Kathleen, you're echoing a little bit.
Kathleen, you're
echoing a little bit. Audio options. I'll jump in. So I can jump in here and ask a few questions. Is the CPOT and BPS better for neurocritical care patients than the nonverbal pain scale, or 0 to 10? Do you have any data to share?
Okay, so I guess this is a question for me. So for both the BPS and the CPOT, we have little evidence on it with this group of neurocritical patients. The only issue we've seen is that we get lower pain scores with them because they don't react as intensively as other patients and they don't grimace as much. So this will impact their global pain score. So we may miss some pain events with this population, but it's still feasible to use them. Just to keep in mind that we may not capture all behaviors in these patients because their reactions are more variable and they don't reach the grimace as compared to other patients. The NVPS, from my knowledge, I don't know of specific studies with this particular ICU group. I just wish to highlight that in the NVPS, there are physiologic signs, including vitals as well. And because of their lack of validity for pain assessment, they have to be used with caution. So we have to be aware of that. And 0 to 10 is basically a the NRS 0 to 10 is meant for the patient to self-report pain, and ideally should not be used as a proxy because it's a personal experience.
Thank you. And another question here is, which takes priority, the self-report or the behavior?
The self-report, always.
And why can the BPS not be used for assessing response to pain medications?
I think it can be used for this purpose as well, and there's been very nice implementation studies with BPS showing that it was useful in assessing the effectiveness of the administration of analgesics, so it can certainly be used for this purpose.
Very good.
I think
this is Kathleen again, and I will direct this question to Erin. We treat a large number of patients with drug dependence. How do you handle patients that you feel may be exaggerating their pain?
That is a great question, and I'm sure a frequently asked question. I think the first part of this answer is communication with the patient. So setting expectations is extremely important. As an example, if you had a patient who is a chronic pain patient who continually tells you in a very calm manner that they need more, their pain is a 12 out of 10, I think you need to sort of define with them what their baseline pain is. We care for many patients who are similar here, and you may find that their baseline pain, no matter what they do at home, is a 7 or an 8. And when you look at the percent change in what they're reporting compared to what they normally are, you can reasonably set expectations that, you know, you're probably going to have some more discomfort here. Our goal is to get you at least back to what you were at home. If we push really hard to get you something better than you were at home, we may actually do you harm. And then the second part of that, is, aside from the communication and setting appropriate expectations with the patient, has to do then with those adjunct medications. And I don't want folks to think that this is a kitchen sink approach, but you really do need to sit down and try and figure out what the baseline opioid consumption happens to be, what doses of other adjunct medications they may already be taking, and what other things you can add to modulate their response to a noxious stimuli. And that's where subanesthetic doses of ketamine, lidocaine infusions, increasing doses of gabapentin, and other things may very well come in handy, in addition to slowly up-titrating and carefully monitoring for response to the opioids that they are getting and that you're going to prescribe.
Thanks, Aaron. Another question. What number on the CPOT is your cutoff score for likely needed pain therapy?
Sorry, I heard a lot of echo. So the CPOT cutoff score for pain therapy is the question?
Yes.
Okay. Well, we established a CPOT cutoff score higher than 2. So when it's 3 and higher, we have enough evidence to support that the patient is experiencing significant pain. And it has been shown that when patients reach this level, it's more likely that they will be in moderate to severe pain. So we do have enough information to trigger an intervention for pain relief and then reassess if it's been effective after. So higher than 2 would be the cutoff.
Thank you very much. So we are reaching the end of our time. We might have time for one quick question. Someone who doesn't agree with the use of vital signs to assess pain. Let me try a response to that. I don't think anyone is saying that you cannot look at vital signs in relationship to other methods of assessing pain. The research does not give us any comfort that vital signs are valid or reliable tools. So say, for example, while many patients do become tachycardic when they're having pain, there are some patients, if they're on certain medications like beta blockers, would not become tachycardic. So the pain is not the only clinical or situational factor that influences the vital signs, so we must, at this point in time, be cautious about using them as the sole method of assessing pain. So I see where we have reached the 2 minutes before the top of the hour. I want to thank you, and our colleague at SCCM has a few words to say.
Thank you, Kathleen. So this concludes today's ICU Liberation webinar. Thank you, Dr. Puntillo, Dr. Gelinas, and Dr. Joffe for your efforts preparing for and delivering this webcast. And thank you to our audience for your participation. You may share this webcast with your colleagues by visiting www.iculiberation.org. Thank you once again. Goodbye.